Okay. So we will going to start first with the FOP part, okay? And then we will proceed towards the task part, okay? So this is the most recent paper we are discussing today, okay? We'll do it quickly because most of the questions are repeated one. So only the new questions we're going to discuss. What is the normal development of a 3-year-old child? So normal development is drawing a circle is the 3-year-old child normal development. Bridge of two 12 cups, no, it's bridge of basically 3 towers. Square is the 4 years. Scissor use is also after 3 years, but most appropriate is circle. Child 13-month-old with nephrotic syndrome, what is contraindicated? So during the immunosuppression phase, nephrotic syndrome, we are using steroids. So we have to avoid live vaccines actually. So use the general rule that live vaccines are contraindicated in the immunosuppression phase. So it's MMR. Mother with the chickenpox infection 14 days before delivery. So mother had an infection which was 14 days before delivery. So that is not related to immunoglobulin use, okay? Coming with the poor feeding, peripheral pulses cannot be detected, weak femoral pulses. So you can see the pulses are very weak. They clearly mention. Capillary refill time 4, received IV fluids, antibiotics, still undeductible. Saturation on 100%. So this is the important clue that despite you have given the basic management, fluids, antibiotics, still the child is not improving. That means this is not related to the the simple sepsis. Probably it's a duct dependent lesion. Age is also very important over here. They did not mention the age over here, but the age is also important, okay? So it's not improving on 100% oxygen. So what you will going to do, you will going to suspect duct dependent lesion, most likely the cardiac lesion, which is duct dependent. So give starred prostaglandin E2, okay? 8 weeks, weight 3.4 kg. And now the current weight is 3.7. Feeding is 125 ml. 6 times per day coming with the vomiting. So you have to calculate it. So just calculate it. 6 multiplied by 6 times per day with the current weight is 3.7 kg. Okay. So the calculation would be, you will going to multiply 6. This is the total number of feed. Multiply by 125 each time whatever the child is taking. So it will be total, total 24-hour feed. Okay. So 750 ml is the total per day feed, and you will now 750 ml. You will going to divide it with the current weight, that is 3.7. So that is telling you that the child is taking 200 ml per kg per day, and your normal amount is up to 150 ml. So most likely that was overfeeding. Okay. That was overfeeding. Okay. Next case is vegetarian girl with the history of upper RTI for 3 weeks ago presented with tiredness and lethargy, and you can see HB is 6, WBC is 5, platelet 60, low MCV. So what is the diagnosis? So over here, even though they mentioned the vegetarian, but even though vegetarian, it is there, okay? Okay, okay. Vegetarian, yeah. No, dear Ariba, it's not iron deficiency. Why? Because iron deficiency is associated with thrombocytosis. Okay, so it's not, its two cell lines are defect, over here HB is also reduced along with the platelet. So, and yes, it's so most likely in the context of upper RTI as well. Yes, even though it's low MCV, it's there. But as I mentioned, low MCV with iron deficiency anemia is associated with thrombocytosis. So it's thrombocytopenia is there, okay? And in the B12 and folate deficiency, we are suspecting either high MCV, And if it is a mixed deficiency, we can suspect the normal MCV, but we will not got a low MCVs, okay? But pancytopenic pictures can be associated with the B12 and the folate. But over here, because low MCV, it's there over here, which is against B12 and the folate. In the B12 and the folate, either you will get the high MCV, or with the mixed deficiencies, like if it's combined with the iron, you can get the normal MCVs as well. But over here with the history of upper RTI 3 weeks ago, so most likely it would be right, aplastic anemia. Good, okay. Now the next case, it's the 14-month baby with the wrist swelling, and you see the investigation. So see, they have given you the calcium values. So 2 is little bit lower side. Phosphorus is also on the lower side, okay. Albumin is normal, 40-gram albumin is normal, because that will tell you about actually the true status of the calcium. So if it's less than 40, so you have to calculate the corrected calcium as well, okay. Alkaline phosphatase is high over here. So what is the diagnosis in this case, okay? So over here, they did not give anything related to the PTH, but you know that phosphate is decreasing, okay? So most likely cause would be the vitamin D deficiency, because if you think about hypopara, both the C and D options, it would associated with high phosphate, okay? So if you can remember, the two important causes of high phosphate is the one which is associated with creatinine function disturbances like kidney failure, or the other is associated with the hypoparathyroidism. It could be pseudo or it could be true hypoparathyroidism. Both condition would associated with high phosphate level. In hypoparathyroidism, if it is isolated hypoparathyroidism, then your calcium levels would be high. Hypoparathyroidism is associated with, it is also associated with primary or the secondary cases, but if it is a primary, especially, it will associated with hypercalcemia, okay? So that is why it's vitamin D deficiency. 8 years female with unilateral. So she's 8 years old, okay? So now as I mentioned, the like age for the precautions is if it is less than 8 for the girls. So the age is okay, 8 years old with unilateral pain, less breast enlargement if it is there. So this is actually the normal, okay? So what you will going to see, it start at 8 years old, okay, and it is, the painless breast enlargement, it is there. So what you will going to do over here with this scenario, you don't have any height spurt is mentioned over here, so you will not go with the precocious puberties, okay. So you will go with the benign versions over here, which is premature thelarchy, if you don't have any height spurt, if you don't have any increase in the bone densities, okay. I'm just coming. So now we'll talk about the next case, a case of girl with hemangioma. What is the most concern? Okay. Rapid growth within first 3 years, more than 3 hemangioma in the torso. and hemangioma in the ear. Basically, it's not they are asking about what is the most concerning feature for me. Okay, for most concerning feature is the if it is a hemangioma in your vital structures. Okay, if it is near your eyes. Okay, if it is your around the ear, for example. So what would happen? You could have hearing loss. Okay, conductive hearing loss, and you could have if it is around the external canal, or if it is deep. Okay, that could involve the hearing. So that is more concerning for me. Rapid growth in the first three years will be okay. It is normally for the first year, but later on it will going to regress. So this is not the concerning. More than 10 hemangiomas, if it is there in the torso, then we can think about the internal hemangiomas as well. So 3 is not a very big number. So vital structures, eye, airway, ear, so that could associated with. If it is hearing issues problem will there, then definitely the child later on can develop with the speech problems. If it is a girl, age is not over here, so that is why I'll go with over here is in the ear. Okay, 1 year had viral infections, and mother complained of difficulty of feeding and breathlessness. Okay, and you can see over here just the viral infection, but if you look at it, heart rate is a 190, with respiratory rate is 45, with liver is 4 centimeter, with bilateral capitation. So you can easily pick up that if your involvement of respiratory with the liver, most likely it's a viral myocarditis. 6-year-old with inhaled fluticasone 200 microgram and salbutamol, but his asthma is not controlled. So what you will going to do with that? Okay, this child is basically taking only inhaled corticosteroids, and this is the mild dose. Okay, 200 microgram, and after that this salbutamol is just the symptomatic or reliever pump. Okay, now if it is not improved, so now the current guidelines suggest that whatever the age, the second line option would be its leukotriene antagonist. Okay, so it's better that you should add leukotriene antagonist. If it is not working, then you can stop leukotriene antagonist. You can add LABA, and if it is not, LABA is also not working, then you can increase the inhaled steroid. So steroid is a third step. So the next option would be the leukotriene antagonist. Okay, to a 12-year-old girl with a 4-week history of wheeze and shortness of breath, no improvement after salbutamol and the steroids inhalers, no history of asthma, history of weight loss. So with the weight loss history, and there is a new origin of wheezes and shortness of breath, which is not improving. Okay, most think about any obstructive, especially think about underlying lymphomas. Okay, so you'll go with the chest x-ray over here, which can tell you the mediastinal mass over here that can present with the non-Hodgkin's lymphoma or the T-cell malignancies, which can presented with the mediastinal mass, especially in the context of the weight loss. Okay, a 3-year-old child with a blotchy rash, and you can see that 4 episodes in the last 4 months accompanied by periorbital swelling. A rash is itchy, occasionally white, lasts for 12 hours. Complain of asthma, facial eczema in his first year of life, soya milk. So this is all related to, we have discussed, this is a most likely chronic idiopathic urticaria is the cause, which is allergic. Okay, 10-year-old child came with the cyanose, confused, he's asthmatic. So cyanosed and confused, we have discussed that cyanosis, if it is there, confusion, like if it's central nervous system involvement, if it is there, you are ending into the life-threatening, and already he's asthmatic on X and salbutamol. What do you do next? So next always would be the call anesthesia whenever you are thinking the child is in life-threatening condition. GI with I know it's not GI, it's probably girl with the learning difficulties and lens dislocation, so that would be homocystinuria. Scenario about the neonatal resuscitation, mother received pethidine and the baby was delivered, which was flat. Cyanosed, you try to inflate the chest with Began mask, but no response and chest is not moving. If no response and chest is not moving with your inflation breath, then you have to airway manipulation. So it's better that you will going to open the airways, whatever the technique you will going to use. You try to open the airway first and repeat the inflation breath. This is the option you will going to go first. Okay, 14-year-old girl occasional stridor. She has difficulty swallowing lumpy food. So with stridor and swelling problem, most likely they're talking about the vascular ring. 6-month well baby, full term, was exclusively breastfeeding. What is your advice for mother for proper technique of weaning? So proper technique is we start with rice and puree vegetables. Okay, so this is the initial start of the weaning. 2-year-old alert child came with vomiting and diarrhea for 2 days. You can see it's alert child, even though vomiting and diarrhea, AG is there, but he's alert, blood sugar is low. So you have to give oral fluids, okay? I've already mentioned if someone is alert, vomiting, it's there, but it's not that interactable vomiting that he cannot tolerate anything. If that severe vomiting is there, then it would be exceptional. Otherwise, you will give oral fluids, okay? Child diagnosed with meningococcemia for prophylactic antibiotic for the meningococcemia is ciprofloxacin, oral single dose. This is prophylaxis for everyone, okay? 7-year-old boy complained about easy bruising, clumsy walking. Father is also involved. Okay, so we have talked about this scenario. This is most likely they are talking because father and boy is involved. Definitely never be X-linked, okay? Because father will never give X-linked conditions to their sons. So remove the X-linked condition. It would be most likely, with the bruising and skin issues, collagen problems are there with the walking problems as well. So most likely it's the Ehlers-Danlos syndromes, okay? 5-year-old child with repeated abdominal pain, vomiting and pallor. Weight is on 0.4 centile with the history of no organomegaly, normal abdominal with hypertension. So you can see over here, this is the repeated abdominal pain, vomiting, pallor, so pale is there, hypertension. This is very characteristic for the CRF, that is chronic renal failure. And you can see the child is not thriving as well, and there is no organomegaly. So most likely with this child, the underlying cause for chronic renal failure would be definitely the congenital conditions rather than any acquired causes. So most likely with normal abdominal examination, you will go with the renal dysplasia, which is actually right answer, okay? Mother has a lymphoma and she does not like anyone to know. She's a conflict with the father. They have a child who has failure to thrive. There is a meeting for discussing the child condition. GP is very close to the family, but GP, what the role of the GP in the meeting? So he will only talk about the information he will give about the child's medical history, how many times the child got admitted, what was the growth centile, how the child is following, so whether the child was vaccinated or not. So he only talk about the child, no need to talk about the family crisis, family problems. That is the function of the or that is the role of the the social people, or the people who are working in the like for example community people. So their role is to talk about the family condition. Your role as a GP is just to talk about the child. Baby with the fever and the vomiting, when to refer the baby to the hospital. So we have already discussed that if it's a drowsiness, if it is there, central nervous system involvement, if it is there, most likely the child is getting encephalitis, meningitis. So you have to refer the baby whenever there is a CNS changes has been started. 8-year-old from Sudan came to you for treatment. So already Sudan treatment and cut from the down, genital mutilation has been done. So you have to call the police. 3-year-old boy come with yellow colored skin of hands and white sclera. So 3-year-old boy, and you can see yellow colored skin is only on the hand, but sclera is okay. Mother is vegetarian. She said he likes to drink too much squash juices. So what would be the diagnosis over here? So squash juices and vegetarians, most likely this color of the skin is due to keratonemia, as because they just very clearly they say white sclera that it rule out actually the jaundice. Okay, so if it's jaundice, if it is there, it must involve the sclera as well. So that is why the other hemolytic conditions would be ruled out. Adolescent girl, 15-year-old, come to tachypneic, heart rate is 500, Difficulty of breathing with tickling sensation, oxygen saturation was 99. So what you were thinking over here, it's basically because of difficulty of breathing, the child have developed hypocalcemia, tingling sensation. So the initial management would be re-breathing back in this case. Okay, so this is repeated one. What is most important at 6 months, refer for the surgery. So at 6 months, it's then hernias, okay? Inguinal hernia are the one which you will going to operate as the child have appropriate weight. You should go with this first, and then you will at 12 months you will going to operate the epigastric hernias, and after 1 year or 2 year, then you will think about the hydrocele. Phimosis is a condition which will going to improve by the puberty, and the umbilical hernia you should wait 4 to 5 years. 10-year-old screaming, okay, and screaming, and she crying along with the palpitation at sleeping, but she cannot recall anything. So this is typical night terror, which you cannot just give a reassurance. You cannot do anything. Okay, so nothing related to the night light routines or camps. You just need reassurance, and it will going to be settled down with the time. Okay, next case. Okay, no melatonin, nothing, no role. Okay, a baby referred by health visitor for non-gaining weight. Okay, so it's the baby referred by the health visitor. Yeah, and he was not gaining weight. Mom says that she's okay, taking formula. Like her siblings, you notice signs of the mild dehydration. So what you will going to do with the mild dehydration, it's better that we should admit and refer to social services, admit and give fortified formula, discharge with fortified, admit and give NG feedings over here. So with the mild dehydration, there is no criteria for admission, okay, because it's the mild. So what's basically they saying that the child is already taking formula like her siblings. He is a health visitor, referred by health visitor for not gaining weight. You notice signs of mild dehydration. Okay, you notice signs. So this is the baby which is referred by the health visitor. Okay, health visitor because the child is not gaining weight, and mom says the child is okay, taking formula like her siblings. You notice signs of mild dehydrations are there. Okay, you need to admit, refer to social services. No, there is nothing to do with the social services. Admit and give fortified formulas, and discharge with fortified formulas. Admit and give NG feedings. Okay, over here, because he was referred and there was a concern of not gaining weight as well. Yeah, is not gaining weight as well. Yes, that's what I'm saying. It's referred by the health visitor. Someone has noticed, and the concern is of not gaining weight is also there. Yes, so that is why we need to admit this child. And then because there is nothing, no vomitings, nothing is there, then we have to give fortified formula in our supervision. There is no need for NG if the child can tolerate. Why, dear NG? NG is also there some specifications. If there is respiratory distress is there, if the child is not taking orally, something it should be there, then only, because tubing, it's NG, it's for think about the parents of UK. Okay, even though if before applying any procedure, any NG, any cannula, you have to take so much concern. Okay, so it's not that easy to perform procedures like in our setup, that just take out and just insert in the baby. It's not that simple. Okay, so I think if there is no such situation, no problems, yes, we can admit. If we have some concerns, directly we will not refer to social services right away. We will going to give fortified formula. We will going to observe the child. That would be the most appropriate way. And then we will going to, yes, give proper feeding. Yes, admit it and give proper feeding. That's the way you can approach if you have some concerns. Yes, absolutely right. So second option is right. 18-month-old with the history of upper RTI 1 week ago. Parents with concern about his respiration. So there is a history of upper RTI, now respiration, tachypneic heart rate is more than 100. He is lethargic. Temperature is 37.8. Chest is clear, look thin. Rest of examination is clear. Apart from the nasal block, his urine bag, which is inserted, and it was full. So that you can see over here, it's very clear that, the child is lethargic, tachypneic, and the chest is clear. That is clearly acidotic breathing is there. You just insert the urine bag and it become full instantly. That it's showing polyuria. Okay. So what do you think what to do next in this case? So I think the next thing would be to look for is over here, the most likely thing over you will think about, because DK over here, metabolic acidosis. So you should go with you should select between ABGs and the random blood sugar levels. Okay. So I think, yes, you can go. Yes, yes, both. You can go because they are talking about what to do next. Okay. So diabetic ketoacidosis, diabetic first in the ER. It's very easy to check the random blood sugar first, and then ABGs we will perform later. So we are suspecting diabetic. Yes, you can go with the E if it is their random blood sugar levels first. Okay. Yes, you are right. Now, mother, old child coming with the 2-day history of intake of amoxicillin syrup for fever, then develop intermittent screaming, pulling legs towards the abdomen and become pale between the attacks. He is well and then develop vomiting for 6 times. There was a streaks of blood. So this is clear intussusception that, it is not linked with actually amoxicillin syrup. Any simple GI infections can lead to intussusception. Okay, this is very typical history. Pains and between the attacks the child is well, and blood is also coming in the stool, so most likely this is intussusception. If a child tested homozygous for cystic fibrosis gene, what will be the risk of his sister to be a carrier? So this is very important that they are asking about. Child is itself is a diseased child. Okay, so if the child is become diseased over here, definitely the both parents become carrier over here. Then only the child can be homozygous if both parents will be carrier. Okay, at least if both parents are carrier, then the child must be homozygous for cystic fibrosis. So what will be the risk of his sister to be carrier? So his sister to be carrier is definitely 2/3. It would be 2/3. Okay. So the answer would be 2/3 of the chance to be the carrier. Okay. Now boy presented with the, yes, very good, Rabia. It's 2/3. Boy presented with asymmetric scrotal swelling after history of trauma during football playing 1 week ago. It's not tender and firm. So if it is, even though they have given you the history of trauma, but you can see it's firm, it is not tender, then most likely it would be testicular tumor. And if it is one-sided, okay? So it's the testicular tumor. Next case. Okay, patient has hot, tender knee joint and has fever and unable to bear weight. Now this joint is already, hot, tender, and fever is also there. What would be the best next step over here is the joint aspiration over here. Okay, so if clear cut swelling, tenderness, pain, fever, most likely that would be septic arthritis, and you will go with the joint aspiration. Picture of the child 3 months coming with his sister, and who is already in child protection for routine examination. On examination, she has multiple dark color spots on her back and buttocks. So we have already discussed this back and buttocks are most likely, the age, according to age, most likely this would be the which time Mongolian. Okay, so this is congenital melanocytosis. Okay, melon is in deep, and that gives you different colors, different shades. So this is congenital melanocytosis, okay? And you need to go with the reassurance over here. This is Mongolian spot, okay? Child came with a history of recurrent. So it's recurrent, it's very important, but with macroscopic hematuria, with the sore throat, and you can see this is protein and RBCs are coming. Ask about what will be abnormal. So its serum IgA levels would be abnormal in the IgA. Nephropathy, C3, C4, and other things will be normal in this case, okay? 14-year-old girl presented with vomitings and severe abdominal pain that was 8/10 with tenderness in the right side. She had irregular cycle. Last period was 6 weeks ago and today she bleeds. Blood pressure is 100/80. There is no fever. So what you will going to do in this case? So what you will going to do in this case? There was a severe abdominal pain, vomitings is there, and the tenderness is on the right side. So right side has multiple causes, okay? It could be ectopic, it could be appendix, it could be the torsion. So many causes are there, okay? And over here, so what you will going to do over here is the, I think, abdomen and pelvic ultrasound will going to tell you what is actually. It will not only rule out, it will check the appendix as well. And over here, uh, she bleeds now. Today she bleeds, okay? Last period was 6 weeks ago, and now today she is bleeds, okay? So I think she had irregular cycle. Last period was 6 weeks ago. Severe abdominal pains and the vomitings. What will you do? She bleeds. Today she bleeds. In the ectopic pregnancy, do you bleed? This is the question. I think we don't bleed in the ectopic pregnancies. Age is also 14. We don't bleed now. So I think menstruation is started now. Today she bleeds. So I think so for the topics. So I think as far as my knowledge, we don't bleed. We don't know what's going on inside, whether it's ectopic or uterine, until unless we check by ultrasound and all that. Abdominal ultrasound will tell you about ectopic, uterine masses. It could tell about the ovarian, testicular ovarian torsion, appendix. So many answers will be taken from abdomen and pelvic ultrasound, especially with severe abdominal pain when you are suspecting any severe condition. Okay. So I think pregnancy test would be have a very limited information rather than especially if in the context of bleeding. Okay. Already had a regular cycle and she bleeds now. So I think go with the abdomen and pelvic ultrasound. Okay. Child hyperactive, impulsive, abnormal behavior, and okay, dear. So the child is hyperactive, impulsive, abnormal behavior, diagnosed as ADHD on methylphenidate, mother complaining is delayed, preparation for school, difficulty in handwriting. So we've already discussed. This is most likely the problem with handwriting, coordination. Most likely this is dyspraxia. Okay, this is C. Child after diagnosis of brainstem death confirmed by 2 consultants, many trials to convince the parents the ventilation must be stopped, but the family will going to refuse over here. So over here, the court will going to decide about it. Okay, you will not going to take action. Over here, it's the judge or the court, okay, that will decide about it. 8 weeks parents concerning that he did not startle to noise. What is the suitable hearing testing at 8 weeks of age? So this is brainstem evoked potentials. BARA is the suitable testing, which will tell you the answer. Tympanometry will just only see the eardrum, okay, the problems related to the eardrums. So in the neonate, we have two type of testing. The best is of course the BERA, and the other is autoacoustic emission. Okay. So over here, autoacoustic emission, normally it's a protocol for UK. They have done autoacoustic emission for every child. Okay. So if it's a parent's concerns is there still, then you will go with the BERA, which is actually checking not only the conductive pathway, also checking the nerves, that is auditory nerves, and the cochlear function as well. Okay. While when you talk about the autoacoustic emission, that will not check the functions of the auditory nerves. Okay. 14-year-old child complained of few months new itchy raised circular lesion in the antecubital fossa on the background of red itchy skin in her flexures. He looks well with dry skin and flexure, now presented with 15 to 20 raised circular pearly lesions. So these raised circular pearly lesions are very typical for the pox virus. Okay. Around the antecubital fossa. So this is most likely the pox virus, or you can say molluscum contagiosum. Teenager girl complained to her teacher that when she participated in school sport activity, she had attack of palpitation and tachycardia. She had history of two prior episodes in the last 6 months. So what is the investigation that helped in detecting the underlying cause of her palpitation? So you will go simply with the 12 lead ECG that will tell you whether you have any underlying extra pathway like WPW syndrome is there or not. That would be triggered with the exercise and convert into the SVT. Okay. So this is a person which is presenting to you with the SVTs. Exercise ECGs we do not perform in the pediatric population. Okay. 24-hour ECG is basically for the very rare type of arrhythmias. But first thing is that you should go with the check for the extra pathway WPW. You can picked up by simple 12 lead ECG. So this would be the, I think, the best that will give you the cause of her palpitations. Child coming with fever, palatal petechiae, large spleen. This is very typical for infectious mononucleosis. Okay, palatal petechiae, especially over here. Otherwise, you can have ALL, but ALL is not only with the spleen. Most of the time, the ALL is with the hepatosplenomegaly. 9-year-old girl presented with 10 days history of fever and the cough. She had responded initially to oral amoxicillin, but now looked ill, stony dullness. You'll go with the ultrasound chest to look for the pleural effusion. Scenario of the child, 5 months with the second attack of lower UTI. Culture showed E. coli responded to trimethoprim within 48 hours. What the next investigation according to the NICE guidelines? You have to perform the ultrasound chest. Okay. Ultrasound KUB. Okay. Ultrasound. Now you have to decide within 6 weeks or ultrasound during infection. So when you see the infection, this is still in the simple UTI, because to actually call it as a recurrent UTI, it should be 3 attacks of the lower UTI. Okay. So if you have a simple UTI, then you have to perform ultrasound within 6 weeks. Okay. It's not during infection. You just go with the ultrasound within 6 weeks. Child has a cough for 1 week and clinically the chest is normal. And you can see full blood count is lymphocytosis. So this is pertussis. Child with the dysuria developed later secondary enuresis. Ultrasound done showing renal stones. Dipsticks are showing proteinuria. Blood is 1 plus. Leukocytes is 1 plus. So what is the cause over here? In this case, with the renal stones and with the proteinuria over here. Okay. So this is the case over here. You can see why you have actually stone formation. Okay. Along with that, you can see proteinuria is also there. Okay. So proteinuria is basically telling you there is a some problem if it's there. Okay. So when we talk about over here, proteinuria could be a part of renal infection as well. Okay, so if you have a UTI, you could have proteinuria as well, little bit blood as well. Over leukocytes are positive over here. and with the renal stone, and the child is complaining of pain, dysuria, okay? So most likely it is a Proteus UTI. So Proteus UTI is associated with the this dysurias or UTI, and this UTI is occur in the Proteus one, okay? Distal RTA, renal tubular acidosis, there will be no proteinuria and blood and all that, okay? Cystinuria is also associated with, Fanconi type picture, Fanconi syndrome like picture, in which you would have a blood glucose and all those things will be coming. Okay. So that is why आपकी बुक्स भी यहाँ पड़ी है बेटे, आपकी ये भी गिर जाएगी, ये उठा लो आप, प्लीज नीचे रख के आओ. Okay, so most likely, yes, this is right, that you will go with the Proteus UTI. Scenario of the child with a short stature and his weight is on 75th, so weight is good. Height is badly affected, but mid-parental height is very good. On the age 3 years, he was okay on 25th. Otherwise, normal, good school performance, okay? And no dysmorphic features. So good school performance is ruling out the hypothyroidism. Otherwise, if your weight is okay, height is mostly affected, this is endocrine problem. And you can see over here whether it is a girl or a boy. They did not mention anything about his height. So probably if we are suspecting his, so we will go with the growth hormone deficiency over here. Okay, I think all of you, it's this point is clear. 3-year-old boy has intermittent. For a girl, if it is there, then I can think about Turner. Okay. 3-year-old girl has intermittent fever for 5 days, right ear pain, right torticollis and muffled cry. So, this fever along with the ear involvement on neck torticollis, they are talking about retropharyngeal abscess. So, what is your immediate infection is referred to the quickly urgent ENT referral, okay? That is retropharyngeal abscess. 14-year-old girl not yet reaching the menarche. During a routine examination, she's found to have a small breast bird, that is B2, and few pubic hair distributions. What her tenor staging? It's B2, P2, okay? Because a few hairs are there, that is why it's B2 and P2. Now, 20-month child with 2 to 3 month history of frequent watery diarrhea with recognized food particles. Weight is on 25th for the last 12 months. Most likely this is toddler's diarrhea. 22-month-old boy drinking about 2 to 3 liter juices per day. 2 to 3 liter juices per day. Frequent nappies with strong history of type 1 diabetes. His RBS was 6.5. Okay, that is normal. Plasma osmolarity is also okay. Urine osmolarity is decreased. That is 95. Then what to do next? So what to do next over here? Over here, you can see that urine osmolarity is low. That is 95. Plasma osmolarity is 285. Okay. Over here, urine is diluted. So this child is producing diluted urine. So we have to rule out whether it is a psychogenic polydipsia, or that is polyuria, because it's a frequent nappies it is there. Is it a psychogenic due to this 2 to 3 liter juices, but is most likely cause over here, or it could be due to underlying diabetes insipidus or mellitus. So I think with the decreased urine osmolarity, we'll go with the water deprivation testing. Okay. This RBS was okay, 6.5, even though they mentioned 3 to 6 normal, but random blood sugar is up to 11, it's normal. So that is why over here with this history and with this urine osmolarity, you will go with water deprivation testing. Okay. Sorry, where we gone? Yes, water deprivation testing. What is the most important in 6 months? We have discussed this question, most important inguinal hernia. Next question is 23-month-old baby coming with 4 to 5 month history of delay, day and night drinking about 2.2 to 3 liters, wetting diapers frequently, family history of diabetes type 1, RB, random blood sugars, probably 7.5, random plasma, yeah, this is same. Again, urine osmolarity, if it is less than 300, and plasma osmolarity is increasing. You can see it's very close to a very high range of the normal. So your plasma osmolarity is on the higher range of the normal. Urine osmolarity 95 means the urine is totally diluted. Normally urine osmolarity should be more than the plasma. That is, it should be more than 300. So again, what you will going to do in this case, what is the next investigation? So I've already shared from your illustrated textbook of pediatrics that the next investigation in this case would be the early morning plasma and the urine osmolarity. So if you have this option, that would be the best. That will tell you about the diabetes. If you are suspecting any diabetes insipidus or something like that, you should go with the early morning plasma and the urine osmolarities first, early morning. Okay, so go with the B first, and then you will go with the water deprivation for the diagnostic purpose. Okay. 14-year-old girl presented with lack of interest, poor school performance, not going with her friends, not refusing investigation. She was refusing eating with weight loss. Family thinks she took toxic. She is not refusing. It was normal. What is the most probable diagnosis? We have already discussed. There is nothing about a significant weight loss, even though in the depression, your weight loss is there, lack of interest, not going with the friends. That is all goes with the depression. 10 years old girl presented by 1 day history of severe abdominal pain and the vomiting. Last period was 6 weeks ago and then still she bleeding. Her periods were irregular. Now she looked distressed, pale, sweating. On examination, lower abdominal tenderness, right-sided guarding is also there. BP is 100 by 65, respiratory at 30, temperature 100, 160, pain score is severe. What would be the best next step over here? Clearly, over here in the 10-year-old, you are suspecting the appendix. And with this appendix, especially, you are suspecting right side guarding is also there. You must go with the CT scan abdomen if it is present in your scenarios. That will not going to miss the retrocecal appendix. Pelvic ultrasound will going to miss the retrocecal. So that is why the best test over here with the temperature is okay, 37, not very high, with such a pain, with right side guarding. So I think you must go with the first thing. What is the best next step for the diagnosis? Next, they are asking about for the diagnosis. Okay, so for the diagnosis, what is the best next step? You will go with over here in this situation, CT scan abdomen. Okay. 2 years old boy transferred from primary to secondary school, become aggressive and angry with his mother. She called the police for him, but at school his request is he is quiet in classroom, school performance is well organized, academic well, but has difficulty with making friends. So most likely this is again a autistic spectrum type disorder. Spectral disorders are, it's a range, as I mentioned over here. It's having problems with making friends. He's more become angry with the mother and all that. So most likely this is autistic spectrum disorder. An obese girl, weight and height is on 98, no abnormalities apart from obesity. So what is the management plan? Weight management program. 8 years old girl treated with vulvovaginous several times with antifungals. Now you can see new partner at home. This is most likely sexual abuse. The child hyperactive, impulse, abnormal behavior, diagnosed with ADHD, methylphenidate. Mother complaining he don't play with his sister, delayed in preparation, difficulty in handwriting. So this is dyspraxia. 8-week-old baby, his mother said he's not smiling and he is not following her. So he's not able to fix. Urgently, you will going to refer to the ophthalmology urgently. Okay, if someone is not fixing and following, okay, normally this fixing and following will going to start by 6 to 8 weeks, and if it is not starting yet, then you directly refer to ophthalmology urgently. If you will going to waste time, then definitely the child will lose his vision. 4 months, come to the pediatric. This is a 4-month-old child with squint, and the squint was apparent during examination. One sibling has neuroblastoma. So what to do over here? So we discussed very clearly that, after 3 months, especially if the child is presenting to you with the squinting, okay? So what you will going to do over here is refer to the ophthalmology. Okay, you will not going to waste time. You will going to refer to the ophthalmology over here. Up till 3 months, you can ignore it. Okay, but the squint was apparent. Okay, it was very apparent. Manifested squint was there. Clear cut squint was there. It was not the intermittent type or latent one. So you will going to refer 3-year-old boy. Mother was concerning about the delayed gross motor and cognitive development. He walked at 18 months, cannot run or climb stairs. He cannot recognize colors or three-step commands on examination. Severe lordosis, Wadlinge. So you will go with the first thing, what investigation you would do to now. So first thing you will go with the CK levels. So runner boy with leg pain, localized swelling. This is 100% repeated. Osgood shelter. Okay. Girl with extensive progressive oligo GIA not controlled by the NSAIDs, and the rheumatologist prescribed methotrexate, found in internet that it is used for the malignancy. So you'll go with the AS rheumatology group, support information advice. Mother known SLE with recurrent miscarriages. What is the most serious complication? It's a third degree or complete heart block that could affect the boy. 13-year-old child with obstructive sleep apnea underwent tonsillectomy. After the operation. He is in ENT ward, took paracetamol and ibuprofen, but his pain is not due for 3 hours. So you will give over here is the, in this case, subcutaneous morphine over here, subcu morphine with the pump, especially those kids who are post-operative over here. Okay. Scenario about the child was cold with the burn by hot coffee. Okay. So this is the child was cold with burn by hot coffee on his left arm and anterior chest. They applied tap water 20 minutes, put cling film, but the child is still distressed, crying with the pain. So you will give instant intranasal morphines. What indicates the NAI the most? Bruises on the back could be Mongolian. 18-month, 2 centimeter bites on the arms. Linear burn in a girl hand. Her mom had straightener. CP with pain in hip when moving thigh. Okay. So what could be the underlying hip pains are there, especially with in the CP child, it is very common that they could have hip dislocations and all that, which is not related to the NAI, which is related to their posture. 18-month with 2 centimeter bites on arm. This girl linear burn in a girl hand. Her mom had hair straightened. So this could accidental. If you have a burn which is your hand, not on the thigh. If it is on the thigh, then definitely I would be very suspicious. But yes, the 2-year-old girl can hold the hot straightener and they have a burn in the hand that is accidental. But the bites, human bites on 18-month baby, that could be non-accidental. So over here it would be B in this case. Okay. We have discussed family is refusing the ventilation to be out. So this will go with the judge, with the court. Now, 8-month baby fell during nappy change. Table has large temporoparietal swelling in his head and is indicated for CT scan. When discussing the parents about disadvantage, so we have already talked about that you will talk that CT scan has a radiation exposure risk, but knowing the diagnosis is important. That's the way you will going to talk. 2-year-old girl, 12 kg. So it's, and you need a dose of adrenaline. So it's 150 microgram. I am 1000 strength. 10-year-old boy returned from school alone every day. Now neck stiffness. So we have talked about this is most likely arachnoid hemorrhage if it is there. 16-year-old girl took 16 tablets of paracetamol, presenting at 12 hours or 24 whatsoever before she come. She had a skin rash when treated for a previous paracetamol toxicity. What you will going to do? You will going to check the paracetamol level and you will give an acetylcysteine as well. We have discussed this question yesterday, okay? Because even if the nitrite is negative, yes, if nitrite is negative, but you have leukocytes are positive, you have dysuria is there, you have renal stone formation is there, you have along with the proteinuria, blood, everything is coming. So yes, there is a possibility that it's UTI, okay? Next case, so we have already discussed that we will send always the measuring the paracetamol level, and at the same time, because she took the 16 tablets, more than 200 microgram doses she has taken, more than 150 micrograms, so you should start N-acetylcysteine, and only the skin rashes is not the contraindication until you have anaphylaxis. 10-month-old infant presented with just the 1 day history of confluent blanching rash. Started on the face, now covered his entire body, miserable conjunctivitis. So this is all measles, okay? 5 days old baby with down. He did not pass meconium from the birth. Presented with non-bilious vomiting, abdominal distension. So in the downs, most likely cause is Hirschsprung disease in this case, especially with the abdominal distension. 8 weeks formula fed infant came with his mother complaining of the vomiting. More than half of his feed. He is well hydrated, alert. Abdomen is soft. His weight on 50th centile. So what is your advice over here? So if he's gaining the weight, he have nothing other than vomiting out. So good positioning before and after feeding would be that only required for this baby. Okay. Known diabetes interesting in football game. So exercise related, I tell you that your ranges of the sugar should be, you see over here, you will take extra carbohydrate should be given if your RBS is less than 7 before playing. So before playing, you should check your RBS. If it is less than 7, you should take extra carbohydrates. That is the answer, right answer. 14-year-old girl hypothyroidism due to Hashimoto's on levothyroxine. She came to you with high TSH and normal T4. So normal T4 could occur if she have started, medication, but high TSH is completely telling you that this girl is not compliant. So in this case, you will going to check the compliance. 2.5-year-old presented with history of pica and also her sister with pica. And if you look at it, he lives in old house where renovation is occurring. HB is 9.7, MCV or MCH is normal, ferritin is normal. So what you will going to check in this case, you will check the lead levels. Okay. Child refugee come recently from sub-Saharan to UK. What is the schedule of vaccine should be followed? So you can see over here that you will going to go with the sub-Saharan से from sub-Saharan से recently move over to UK. So you will give BCG in this condition, okay, because it's coming from such area. So BCG vaccine, and then you will give UK vaccination schedule. And the age is also important. If the age is, more than I think 15 months, if it is there, if I'm not wrong, you have to check it, then you cannot give the rotavirus. So age is very important. If the child age is, I think, more than 15, more than, I think, 8 months. I'm not 15, sorry. If it is more than 8 months, I think, you cannot give the rotavirus. So over here, it's a child. So you will give without rota. So you will not give rotavirus over here. The correct answer is A over here. Okay. This is the repeated question. This is chronic idiopathic urticaria. Uh, Now, next question is that, okay. Patient diagnosed with the measles after 10 days developed seizures, tonic-clonic, did receive lorazepam. Seizures stop, drowsiness, unresponsive, fundoscopy is normal, no focal abnormality, it's there. So what you will going to do in this case? So this child, most likely what you will going to do in this case, we discussed that case before as well. After measles, you have measles encephalopathy, okay. This child developed seizures, tonic-clonic, but the child become drowsy and unresponsiveness, okay. Fundoscopy is normal, no focal abnormality is there. So what you will going to do in this case? You can go with the imaging as well to look for the signs of measles encephalitis. Yes, you could, no focal abnormality, nothing. LP as well. Even if the nitrite, you can go with the LP because there is nothing over here. Fundoscopy is normal. But the poor GCS is there. Fundoscopy is normal. No focal abnormality is there. Drowsy and unresponsive over here, the child is. So yes, this is very confusing question. In this case, you're suspecting the post-measles encephalitis. Post-measles encephalitis, how to managed? Quickly look over the NICE guideline related to post-measles encephalitis or measles encephalitis. Quickly, I'm just checking. Maybe I got some good information. See what they are saying over here. Measles encephalitis is a rare but severe complication of the measles, causing inflammation of the brain with symptoms like drowsiness, headache, vomiting, appears 7 to 10 days after measles rash. It's the life-threatening condition that can lead to permanent brain damages or death. The primary risk factor for contracting the measles would be the same. So that was all encephalitis. Measles encephalitis is there. This is we know. Mm. I think measles encephalitis, we can go with the LP. Unresponsive, we can't do LP unresponsive. Normally in the unresponsive child, we go first with the imagings. We look at the second measles encephalitis. Management. NHS, I searched it before as well. NHS investigation for suspected measles encephalitis include blood and CSF testing for measles antibodies and RNA, then brain imaging MRI, CT scan to detect brain inflammation, and then EEG to assess the brain wave activity. A lumbar puncture is required to obtain CSF if measles is suspected. Local health protection team must be notified for advance and community contact tracing, and any case of suspected encephalitis require urgent medical assessment. CSF भी लिया जा रहा है for checking the measles antibodies and measles RNA. So I think we'll go with the first is the without any focal involvement with the normal fundoscopy, we can go with the lumbar puncture because definitely you will be unresponsive, drowsiness if it is encephalitis is there. Okay. So if you don't have any focal abnormality or no fundoscopy is entirely normal, then you can go with the EEG. Okay, over here first. Then you will go with the yes. Yes, so we can do LP safely. Yes. Yes, you are right, doctor. Toddler asked to buy something from supermarket. His mother refused. Excessive crying becomes cyanosis. So this is most likely the which type of anoxic reflex seizures are there or anoxic reflex or it's not basically it's a breath holding spell. It's not the anoxia. No, this is not right. Anoxic is most important for those children who are not become cyanos, rather they become pale. So options are not properly over here. So you can write pseudo seizures, okay? So you would say pseudo or breath holding spells, okay? Anoxic reflex is different thing. It's the palate spell. It is not the cyanotic spell, okay? So don't be confused with the anoxic reflex. 10-month baby presented in bronchiolitis season with wheezes, saturation 98%, mild accompanying. What is the risk of developing respiratory complications in this case? So this is a 10-month baby in with bronchiolitis season with wheezes. Saturation is okay. So what is the, which baby, what is the risk of developing severe? So pretermer 27 weeks discharge home. This one is having more likely chances of having severe RSV infection. Term baby with history of ventilation, no. Positive swab, no. Parental history, no. Heavy smoker parents, most likely A is the right, which is the severe risk factor for severe RSV infection. 8-year-old boy who is taking 750 microgram daily inhaled fluticasone. So it's high dose fluticasone. And this is, we have discussed that he developed a cough last week and he become very lethargic after short episodes of vomitings. So most likely you will going to check for the short senectin testing to look for the hypothalamic pituitary axis. Okay. नहीं Ariba, if it's a child is crying, then the child become blue, na cyanosis is there, so cyanotic spells are there. It's not reflex anoxic seizures in which the child become pale, okay, because of any, the child is not crying priorly. In that scenario, the child with the sudden trauma, sudden head trauma, or sudden change, then for example by seeing the blood or something like that, so any sudden change will lead to the activation of the vagus nerve that ultimately leads to the pillar, and then the child will become, collapsed. So the blue and this color will not be there. So that is why you will not going to label it as an anoxic reflux seizures over here. This is the cyanotic spell, or it is, if you don't have cyanotic, then you can go with the pseudo seizures as well. In this is the broad term for this condition. Okay. Newborn is heavy meconium stain with the history of PROM at first stage of the labor. Okay. Mother delivered with prolonged labor for 36 hours. Baby cried immediately, then become vigorous. What to do next? So we have already discussed what to do next in this case. You don't need to do any ETT suction. You just need to do observation for this child. That's all you will going to do with the vigorous baby. Term baby born at home. Term baby born at home, coming with oozing blood from the umbilicus on fourth day, breastfeeding well. So what is the investigation? So most likely investigation, you will think over here hemorrhagic diseases of the newborn, because it's a baby born at home. So you will going to do the prothrombin time over here, PT. Okay, so prothrombin time you will going to perform. PT and APTT both. Yes. So if it's not there, so you'll go with the PT first. 10 days newborn, small baby, microcephaly, petechial rash, but there is no, it's important is microcephaly and small baby. With the petechial rash, no hepatosplenomegaly and failed neonatal hearing testing as well, but overall the child is well. Platelet count is low. So what is the diagnosis? Most likely this is CMV, okay? So in the CMV, you can see the microcephaly is there. The baby is IUGR. The baby is having failed neonatal hearing scan along with the thrombocytopenia. So this thrombocytopenia is due to the CMV infection. Okay, the other features is suggesting CMV. Now the female diagnosed as seasonal sinusitis and she has exam after 3 days. What is your advice you will going to do? After 3 days she has a test and she is just the seasonal, so you can give oral cetirizine, which is low sedating, starting this evening for 3 days. So that's the only management. You can go with the seasonal sinusitis without any steroid use. Okay. So we have finished this document 341. Okay, time is up.
Dr. Aisha, I have two questions, please.
Yes, yes, sure, you can ask.
Okay, so for the first question we have discussed, I think it was on the first or second page. We were discussing a case of vegetarian girl presenting with upper respiratory tract infection, having a picture of pancytopenia with low MCV, and we
Hmm.
diagnosed this case as aplastic anemia. But in
Hmm.
aplastic anemia, it could be normal MCV or high. It can never be low. But for iron deficiency anemia, if this is the case of severe iron deficiency, the patient can present with thrombocytopenia as well. So please, uh,
No, no, no. And Ariba, iron deficiency anemia is very, very typical with thrombocytosis. It is never present with thrombocytopenia.
no, this is written in our book that in severe cases of iron deficiency anemia, it can present with thrombocytopenia or pancytopenia picture. But aplastic anemia cannot present with a low MCV picture. It can never be because there is the faultage in the RBC production. So there are very few or large RBCs that show appear and they will cause a higher MCV or it can be normal, but it can never be low.
Okay, can you share this picture on the group?
Okay, I will share it.
Okay, okay.
And for the second question, we have two questions we came across with 14-year-old girl present with the sudden upper abdominal pain right side. I don't remember the whole question, but
14-year-old
if
old girl. Okay.
if we suspect this case as a case of ruptured ectopic pregnancy, then
Hmm.
we have to exclude pregnancy test first, and then we can go for ultrasound and other testing. Why not pregnancy test first?
Over here, she was bleeding, start bleed. Even
It
if
could
it
be
is a ruptured ectopic or ectopic, they will not going to bleed. So she was started menstruation, she was bleeding. That is why I was saying that this is not a case of, actually we
but
are suspecting ectopic, but in the ectopics we don't bleed. Do you think we bleed?
no, in case of ruptured ectopic, they do bleed, and this is a medical emergency. They have hypotension and they came into the septic shock. This is a medical emergency. They
Okay.
came with bleeding.
Okay, they can present with the bleeding.
Yes.
Okay, so bleeding can occur in the ruptured one, you can say. Okay. And it's the 6 weeks duration. Actually, duration is also very 6 week duration is
But she was having irregular period. It could be more longer than that.
but
We
age is very favoring now. 14-year age is very close to towards ectopics. Especially,
yes.
a 6 week duration is also there. 6 week duration is also there. So yes, it could be because I was confused with the the bleed. Okay, probably the bleeding part is it's not that prominent in case of I think ectopics. But if you are saying it's bleeding could be there, that with the 6 week duration, yes, our main differential, especially in 14-year-old girl, we should think first about the ectopics rather than other things.
Sorry, ma'am.
Yes, yes, yes,
Ectopic
Dr.
in this
Gautam.
age, it is not common, first of all. And the second thing, it is more of severe pain. They are coming with severe pain. This is the main feature. If it is rupture, also it will be in shock state. It will be like septic behavior with bale and shock. But this is not the case here. She's bleed might be irregular. She had irregular cycle. It could be ectopic pregnancy, but it could يعني this is as one of the diagnosis, but it is not the fairest possibilities.
What were the points that you were saying? Sorry, can you repeat it? Which were
She
against?
said it could be rupture ectopic pregnancy. She's 14
Okay.
years, which is in this age, it is not common like rupture ectopic pregnancy. And
Oh,
if we have ectopic pregnancy, the main feature is the pain. They are coming with severe abdominal pain and tenderness.
okay, so
If it
pain
is
was there.
rupture, it will be in shock state.
Okay. Okay. So blood pressures were okay, 100 by something in that case.
Yeah.
Okay. They were coming most of the time with the shock. Okay. So it's very close. So now it's all up to you. You can go. Emergencies may most of the time, we go with the ultrasound and imagings. Especially if we have CT now, we go with the CT even. Because severe pain, the right sided things, they most of the time picked up. We have focused ultrasound nowadays, so we go with ultrasound first. I don't know what that is why, because many things will be covered on the ultrasound. That is why I was preferring. But
Actually,
yeah.
Actually, as routine in our clinic, we are used to do first, as she said, Dr. Arif said, we do urine pregnancy test, but this is will not cover all the differential diagnosis. And it could be
That is why
negative, but it will
imaging
not
will
kill it.
tell you.
Mm.
Imaging is superior. Even if it is CT mentioned, we can go with the even CT as well in such situations, where there is a severe pain, so that we can see the whole overall picture, what is an actually the emergency is. So I think, Ariba, with the blood pressures normal, with irregular cycle, she bleeds. And yes, you are right. Age is reproductive, age is there, but I think ultrasound will going to pick up the ectopic pregnancy as well. I think at 6 weeks, especially if it is there, it will be picked up by the ultrasound. So that is why prefer the imaging first. Okay, in the emergency situations. Okay.
Can you please share the ectopic pregnancy guideline, or you can share the picture so we can make our concept in that case?
Okay, first we quickly look over the task paper. It's a solved one. So then we can, I'll going to, read that part and then I will share it, inshallah, the relevant part for you people, okay? Okay, we're going to quickly look over whatever new questions are there or not, okay? 6-year-old come to here with the wheezy chest, saturation is 94, heart rate is 130, respiratory rate 30, took 6 puff of salbutamol through the large spacer with valve, then crying, heart rate is 150, respiratory rate is 40 now. Now saturation is 86. So what is actually going on? So the child is, the child is crying, then crying. I don't know, it's crying, I think, written over here. And they're asking about what is going on. So if your respiratory rate over here is initially 30, then it becomes 40. Heart rate is 130. He's crying as well. Saturation is 86. So what do you think? What is it? So there is it could not be exhausted, because in the exhausted state your heart rate will going down, your respiratory rate will going down, the child is active, he is crying over here. So you cannot say over here that probably this, yes, it could be possible, this is a 6-year-old child, that you could have the inappropriate dose of salbutamol. That is why you have some worsening, inappropriate dose of salbutamol. Ventilation perfusion mismatch, actually VQ mismatch does not occur in the asthma condition. Okay, VQ mismatch, probably if it is severe involvement, like for example pulmonary Q, if we talk about, if it's a pulmonary embolism or something like that. Ventilation, if it is lung collapse there, ARDS is there, then we can think about the ventilation perfusion mismatch. So in this crying baby, most likely this is okay. Exhausted one would be with the decrease heart rate and decreased respiratory rate rather than. So that is why I think the B is okay. Action of carbamazepine is okay. This is repeated one. Action of lorazepam. Lorazepam is, again, it's a benzodiazepine, so it's work on the GABA. Mechanism of action of gentamicin. Mechanism of cough, that is all repeated one. Mechanism of action of acoustic emission testing. So emission testing will
Madam,
test.
please share the screen.
Oh, I'm not sharing. Oh, sorry. Let me share the screen. Sorry, मुझे idea नहीं था. Okay. This is the screen in front of you. Okay. So I'm quickly telling the above part. So this is all answered one. Okay, so mechanism of carbamazepine, lorazepam, gentamicin, mechanism of cough, acoustic. So we're talking about mechanism of acoustic emission testing. So emission testing is basically check till the cochlear function. It does not check the auditory nerve. Okay, so auditory nerve and brain involvement cannot be checked by the autoacoustic emission testings. Okay, so this is right. Genetic testing for Prader-Willi. So we all know Prader-Willi or Angelman syndrome. Their problem is either you have a deletion or you have methylation problem. So that is why you check for the DNA methylation over here. Okay. In this case, Prader-Willi and Angelman both. Now newborn discovered, and you can see over here that they have blisters along with the nail changes. So this is most likely the dermoepidermal junction. Now, girl with polyuria and polydipsia, and you will going to diagnose as a psychogenic. So for the confirmation, you need water deprivation test. Coronary sinus drainage is occur in the right atrium. CSF production in CSF choroid plexus, while absorption occur by the arachnoid villi. Test of two unpaired groups, and the data is skewed one. So you can easily pairing and pairing. We have already discussed for two groups. We'll go with the Mann-Whitney because student test and ANOVA both are the parametric testing, which cannot be occurred with the skewed data. Okay. Skeletal survey doing for NAI, which of the following? So you can see over here that skeletal survey doing for NAI? Which of the following? Baby with recurrent attacks of apnea, linear fractures, or with the baby with the posterior rib fracture. So in the posterior rib fractures, more likely this is NAI, so you will go with the skeletal survey in this condition. Child came with the loss of sensation in his foot after his brother hit him with the bicycle. Then he had a foot drop. So what is the nerve which is involved in the foot drop? So this is common peroneal nerve is associated with the foot drop. Long QT because it is 520 more than 460 or 470. So which medication is in erythromycin is the one. In DK, what leads to hypokalemia? So in the initial DK phases, it's the osmotic diuresis, but after treatment has started, then hypokalemia is mediated by insulin therapy. Germ cell tumor, you will check the beta HCG level. CEE is for prostatic hormones. Alpha fetoproteins in most of the time is associated with, neural tube defects as well. Okay, so the germ cell is more linked with the beta HCG. Long QT, how to correct? So this is a formula. This is not the P, it's RR. QT divided by under root RR. Okay. Next, 14-year-old with painful groin lump and painful defecation. What is the cause over here? So this is a 14-year-old girl, and you can see it's a painful groin lump it is there, and painful defecation if it is also there. Lump hai, groin lump hai. The groin lump is probably they are talking about inguinal lymphadenopathy because it's the groin lesion and the painful defecation as well. So what is the cause over here? So they're talking about which type over here. Why painful defecation? Painful defecation, painful groin lump. This is 14-year-old girl. So this is why it's not about groin lump they are talking about. Painful groin lump means painful inguinal lymphadenopathy. Painful lesions are not papilloma, they are warty lesions, they are not painful. Herpes simplex is most of the time associated with the ulcerative lesions. It is not cause groin lump. Treponema pallidum is a painless because it is a syphilis. So I think you, what is chlamydia trachomatis? It causes lymphogranulum. No, it could be no. What is it's associated with papilloma virus, HPV, that are painless. That are painless. Treponema pallidum, it's a syphilis. It is also painless. Painless lymphadenopathy. Painless lymphadenopathy in treponema pallidum. It's not painful. So for the painful, maybe it just the exclusion. You go with the chlamydia trachomatis. We have certain condition in which we have painful groin lump. One it is inguinal, I cannot exactly remember. Lymphogranulum inguinally. Why painful defecations? Painful defecation because of ulcerative lesions, painful as well. The one is called Ducrey. Hemophilus Ducrey is also associated with the, ulcerative lesions could be painful. So it's a painful ulcerative lesion probably in that area and around the anal or associated with painful groin lump. So both things are painful. So if one is condition is called Haemophilus ducrei, the other is called inguinal lymphogranulum. So these are the things which are, I think, painful. So I'll check it later on. Just take a screenshot. We'll check it. I'll send it. What are the conditions which are painful? What are the painless? So I'll share the chart with you, inshallah. So just take picture and remind me. Girl, 14-year-old girl play sports, hematoma in calf muscles. Which factor is associated with it? Over here, the main thing is that hemophilia, both A and B. This is more, why is painful? I've answered ulcerations because proctitis. Proctitis, I search it says associated proctitis. Proctitis with the chlamydia. Lymphogranulum venereum. What is the organism with lymphogranulum venereum then? Organism name, can you tell me? Chlamydia is there. Okay. So this is associated with painful lymphadenopathy. Yes, Rabia, you are right. So if it's a lymphogranulum venereum, it's chlamydial trachomatis, it causes proctitis. That is why you have a defecation problem and you have painful in lymph nodes. Okay. So thank you, Dr. Rabia, for helping us. Okay. Now, 14-year-old girl plays sports, hematoma in the calf muscles. Which factor is associated with this calf muscle bleeding? Over here, when we talk about the hemophilia B is also X-linked. Check it. Hemophilia B, is it X-linked? Because it's a girl. In the girl, X-linked conditions be very rare. I think I can remember both are X-linked, but let me check. Hemophilia B. Both are X-linked conditions, na? Hemophilia B. Hemophilia B. Inheritance. X-linked recessive pattern. So this is also X-linked. Females have both involvement. It is there. Then only they will going to have this condition. Okay. Factor 7 problems with the factor 7 in the calf muscles. Factor 7 deficiency present. How factor 7 deficiency will going to present? X-links are very rare. Both are X-linked, rarely in can cause rarely in yes, it's very rare in the girls. So let me check the factor 7 deficiency how factor 7 deficiency present. How factor 7, because they can also present with the bleed. Factor 7 deficiency present. Factor 7 deficiency. Present. Factor 7 deficiency also presented with the ranging from asymptomatic to life-threatening. Common symptoms include nosebleeds, easy bruising, prolonged bleeding, easy bruisability, nosebleeds, gum bleed, more serious involving bleeding into joints, soft tissues, GI tract or brain. If woman heavy or prolonged menstrual bleeding, menorrhagia is a frequent symptom. So easy bruising with minor bleed, nosebleed, gum bleed. More serious symptoms can occur with hemarthrosis, soft tissues. So I think with the girl, we cannot go with the hemophilia factor 9. We can go with the factor 7 because this is the girl. Cannot say in the 9. If it is a boy, then it's okay. But if it is a girl, we can go with probably the factor 7 deficiency. Okay. So I think most likely in the girl, they'd say factor 9, but I'm not agree over here with the factor 9 in the X-linked conditions. Okay. So just mark this question, probably factor 7, okay? Factor 11, I don't think so present with the bleed, no. Factor 13 present with the bleeding. Factor 7 presented with the bleeding, yes. It can be factor 7, yes. It can be factor 7, most likely, okay? Now family pedigree was given, only males were affected. So most likely if males are affected, then you go with the X-linked recessive condition, which is G6PD. Site of secretion of the ghrelin is the fundus of the stomach. Mechanism of action of atomexetin is a non-adrenaline. Reuptake drug make decrease in platelet aggregation and interstitial nephritis. So this is ibuprofen. Antiarrhythmic drug delay action potential but not affect the conduction velocity. It's talking about the antiarrhythmic drugs delay the action potential but not affect the conduction velocity. It's delay the action potential but not affect the conduction velocity. It's a difficult question about imidrone. It delays the action potential but not affect the conduction velocity. How then it delay the action potential? Imidrone mechanism of action. Let me check it. Immunodrone mechanism of action. Immunodrone mechanism of action. What they say, it blocks potassium, okay? So it blocks the potassium currents that causes repolarization of the heart muscle during the third phase of the cardiac action potential. As a result, it increases the duration of action potential. Okay. So basically, imidrone is working on your potassium. So it is working on the repolarization phase. So if it is working on the repolarization phase, so that is why, as a result, imidrone will increases the duration of action potential as well as the effective refractory period. Refractory period is the period in which the cell cannot stimulate it again. This is called refractory period. You cannot generate second action potential when the cell is in the refractory period. Okay, so that is they are saying about that. What do you mean by conduction velocity? Conduction velocity. Conduction velocity, I think, is related to the, let me check what is conduction velocity. So imidrone slows the conduction velocity by primarily blocking the sodium channel, which reduces the rapid influx of sodium ion that causes heart's electrical impulse to propagate. It also has a potassium channel blocking effect, which prolongs the heart refractory period, and calcium channel blockade as well, that decreases the heart rate. So the overall result is a depressed electrical impulse, slowed conduction, helping to control irregular heart rhythm. So that was the mechanism of imidrone. Now what they are saying, they say delay the action potential but not affect the conduction velocity. So conduction velocity is working on the sodium channels. So they are saying that, which we just I searched, that imidrone is associated with the decreased conduction velocity as well. But mostly they say this is class 3 antiarrhythmic drug, which is primarily working on the potassium. Imidrone के साथ they saying it slows the conduction. होने वाली है बेटे. So with decrease in the conduction, so everywhere I searched 3 to 4 places, they were all saying that it is associated with decrease conduction. Conduction is associated with the sodium entry that will leads to the up spike. I'll just tell you if I can. Okay, so this is actually the part that if we make, the action potential, this part is mediated by sodium. Then we have little plateau phase. Then we have this part. This is called repolarization phase. This part is called repolarization. This is called depolarization. This is called plateau phase. So this repolarization phase, imidrone is working. Okay. So it will prolong the repolarization phase. Depolarization, if it is affected, it will associated with the conduction velocities. So I think we need to search all those drugs, especially calcium channel is a viramipil, which is working. It's not working associated with the, it's decreasing the heart rate. They were saying calcium channel blockers. But we have to search, I think, these 3 to 4 drugs in the context of which one is associated with. So I'm going to search it, just marked it and take a screenshot. I'm going to search it because imidrone is not the right answer. Imidrone decreases the conduction velocity as well. Okay. Now, next case, child come with dilated pupil. So sympathomimetic is again hypertension, hyperthermia, tachycardia. So this is most likely, this is sympathomimetic drug is there. Okay. Now, 3-week baby with the vomitings, hypokalemia. This is clear pyloric stenosis. Mechanism of action of nitric oxide we have done. Theophylline, this is done. A neonate presented with gram-negative diplococci. So negative means it's the Neisseria, because it is diplococci, Neisseria meningitis, Neisseria gonococcal. These are the two infection which is gram negative. Okay, so this is a part of the microbiology. We have discussed those things. Adenosine affects the AV nodal hemophilia B is X-linked genes present on X chromosome. So it can occur in hemophilia B is an X-linked gene. I know it's X-linked, Ariba, but hemophilia, you need 2X to be involved, then only, okay? 2X to be involved, then only they are present. It is very, very highly unlikely to be present in the females, okay? That's why we were saying factor 7, but I'll confirm it. Okay, next is adenosine affects the AV nodal conduction, so it cannot be the answer. Class 3 antiarrhythmic least affect the conduction velocity, and imidrone is class 3. Yes, imidrone is the class 3 drug. So that is why I think they are preferring because class 3 is working on the repolarization phase, as I just mentioned about it. They say they less work on the sodium phase. So probably that could be the reason over here. Yes. So other organisms, GBS, Streptococcus, they are all group positive. Okay, they are all group positive, gram positive. So this is all in the microbiology section. Now, baby with the hypotonia and bilateral ptosis responds to pyridostigmine. Mechanism of action of pyridostigmine acts on which receptors? So this pyridostigmine acts on the which receptors? It's the muscarinic receptors is working on your gland muscles, which we just discussed, that the which is controlling your eye muscles, your pupils. Okay, so this is most likely nicotinic receptors, which is working on your skeletal muscles and all that. Okay, mechanism of action of retinoid, this is decreased follicular, this is repeated one. Parathyroid, baby came with generalized seizures, all labs normal except calcium is 1.2. So what you will going to investigate? Okay. What you will going to, just a second, where the file, my file. What happened to the file? Okay. Okay, so we have discussed this part, fustigmine, this parathyroid hormone, because calcium is low, so we will definitely check the parathyroid hormone levels. Okay. Okay. What is the tetralogy of Fallot? What is the cause? It's the outflow obstruction. Okay. I'm just coming. Okay, okay. Okay, okay. Okay, so this is tetralogy. We all know this is outflow obstruction because it's a subpulmonary, because of the muscle is going to be contracted. Okay. Now sickle cell disease, father has a sickle cell disease, mother is the carrier one, pregnant with monozygotic twins. So we have discussed this case as well, that 50% chance that the girl would have affected, and both girls will affect simultaneously because it is monozygotic. Okay. The child on ALL, uric acid, how uric acid is elevated, it is because of the nucleic acid, that is DNA destruction is more prominent. Okay. Now, baby, you can say over here on second day, respiratory rate is 70, saturation is 80, cyanotic, axis is 140. So you should know the normal axis, that where this, 140 will going. 140 is beyond 90. Okay, so beyond 90. So this is towards the right axis. Okay. So what they are saying, that all pulses are low, no murmur. X-ray shows bilateral opacities. Okay. So this is most likely, if it is all pulses low, then this is most likely, the condition is called, what do you say, H. This is hypoplastic left heart syndrome. That is why your axis is also towards the right axis. Okay. So all pulses is very typical for the HLH. Baby 4 kg with jitteriness, glucose is low, insulin is in the normal range, and you can say glucose is 2.1. So what do you think? What is the cause of this? So defect in glyco, the baby is 4 kg. So over here it's, the baby, it's, there are they saying that baby age is very important. The glycogen lysis break means this is, the storage disorder, glucose storage disorder. So, okay. So in the presence of hypoglycemia, you don't want any insulin. It should not be, undeductible insulin there. Okay. So age is very important. If it is a newborn and healthy baby, okay, just the newborn with so high weight, in that case, it would be transient hyperinsulinism. But if it is 6 to 7 month baby with this weight, okay, then with the liver and all that, then you will going to suspect defect in the glycogen lysis. So if it is a baby which is born with good weight, so you will go with the transient hyperinsulinism. Transient hyperinsulinism, even if the insulin is coming in the normal range, you don't expect a drop of insulin in the presence of hypoglycemia. Okay, so that is why you see the age that will going to decide. Glycogen lysis will not going to present very early age. Paracetamol metabolism in children is glucuronidation. In the neonates, it is sulfation. We know that. Now, the next case over here is the 14-year-old girl presented with shortness of breath. And if you look at the FEV1, which is very low, Z-score is minus 3.3. And if you look at the FVC, which is, the Z-score is minus 0.4, that is normal. So it is primarily affecting the FEV1. Then most likely this is the asthma condition. CGD is a problem of the neutrophil oxidative burst. We all know that. Preterm, 26 weeker and on enteral feeding, which is established and having hyponatremia. So we discussed that case. Most likely immature renal tubulars, especially if they are under 28 weeks. Okay. Now they talk about retrospective. If you go back and checking MRSA increasing case in the last 2 years, so most likely this is case control studies. We have talked about this case in discussion. Okay. 8-year-old girl with mother, she has a new partner. Which of the following can suggest sexual abuse? So if I have a positive culture of chlamydia in the urine sample of 8-year-old, this is right, because anogenital warts can be present in 18-month-old girl that can transfer from the mother, and that is not a part of STD. We have discussed it. Conjunctival swab for Neisseria is associated with, again, very uncommon eye infection. This is common in the neonates. Okay, so this is right. The A is right. This chlamydial infection is STD. So that is reflecting that sexual abuse. Normal development of adult, what increases risk behavior? So risk-taking behavior is associated with prefrontal cortex. Okay, now 15-year-old obese child, BMI 30, polyuria, glycosuria, anti-GAD antibody. So I very specifically I said, if you have antibodies are present, this is type 1 diabetes. Even though this BMI is high, obese child, most of the time the type 1 diabetes are the linear in children, but anti-GAD is very specific for the type 1 diabetes. What added PCV after conjugation? So if you add conjugation, it will improve the immune response, okay? Microarray, what it basically checking in missing or extra DNA, we have discussed it. In peanut allergy, what is the cell responsible for presenting antigen cells? So presenting antigen cells in the epithelium is the dendritic cells are the antigen presenting cells, okay? TOF develop at which stage? TOF develop at, this is not TOF, it is tracheoesophageal fistula, which is developed in the embryonic phase. Lysencephaly is the migration problem. Breast milk, which has a component of anti-infection, is the IgA antibodies. Now, neonates, we have 3-week has goiter, big, the goiter means big thyroid is there in investigation. So high TSH and low T4. So most likely this would be the hormone synthesis problem, because if it is a development problem of the thyroid gland, it would not associated with the goiter. Which of the following is an example of aneuploidy? So it is X, XY or XYY. This is 47. This is right. And what is the commonest cause of unconjugated hyperbilirubinemia in the neonates? Okay. So we have different enzymes are written over here. G6PD, UDP, glucuronide transferase, beta glucuronidase. But they are asking what is the commonest cause of unconjugated hyperbilirubinemia. Okay, so UDP, glucuronide transferase deficiency, if it is there, it is rare, which is associated with Crigler-Najjar. Okay, so this is unlikely. This is very rare condition. Beta glucuronidase is associated with unconjugated, but it is associated with the prolonged jaundice. So I don't know the scenario would, it's not, if it is early onset they are talking about, then you can think about G6PD. But for beta glucuronidase, this is enzyme present in the breast milk, which leads to the delayed or prolonged jaundice, okay, which is also unconjugated one, okay. Girl presented with diarrhea followed by puffiness, lethargic, petechial rash over her body. So definitely after diarrhea, if you have petechial rash, puffiness, this is ARF, creatinine is high, hemolytic uremic syndrome over here. The answer 1 is right. What is the cause of this electrolyte finding during refeeding? So refeeding may why you have decreased potassium, decreased phosphorus. This is because of the intracellular shifting of the electrolyte due to the sodium potassium ATPase. Now they are talking about what is the actually the you can say how you will going to diagnose the death. So death, we have absent cranial motor reflex is the one, because asymmetrical pupillary reflex does not show brainstem death. Absent pupillary reflex is showing the brainstem death. Okay, 5-year-old boy with a scanty pubic hairs but enlarged testes and the penis. So starting with the testes and penis, and bone age is also 9.5 years. So this is most likely associated central, and central is mediated by gonadotrophin. Okay, how they write the strength of the study? So this is systemic review, RCT, cohort, case control. This is absolutely right. From high to order they are asking. So this is a right order. Next, neonate with the biliary atresia operation done. Now mother says he has diarrhea and he's not gaining weight, and she said he is on formula. Okay, so what you will going to do, because this is the child is not able to absorb the fat, because biliary atresia is done, even the operation has done. So you will going to convert medium chain triglyceride diet. Okay, so you will specifically enhance MCT diet along with high carb and high protein. Trimethoprim, we have discussed this mechanism. Another scenario of 9-day baby with suspected respiratory alkalosis with IMD. I'm not sure. Respiratory alkalosis is only specific with the urea cycle disorder. So that is why we're going to opt for that. Chronic renal failure, what you will going to expect, very common, that high PTH along with the low 125 hydroxy vitamin D. Patient with abdominal pain, petechial rash in the lower limb buttocks and diagnosed as HSP. So underlying the pathophysiology is IgA-related vasculitis. Okay. 6-year-old girl with the recurrent vomiting followed by drowsiness and the confusion precipitated by recurrent infections. Brother died in infancy due to the inborn error of metabolism. So what is the enzyme? So over here, what they're saying that with recurrent vomiting followed by drowsiness and confusion, which is precipitated only by infection. Okay. And SID history is also there. So that is why they go with the MCAD. Okay. So MCAD is specifically, as I mentioned, that drowsy hypoglycemia is linked with the infection. Now, when we look at the ABG, 7.35, this is the normal ABG. PCO2, you can see over here is 2.4, which is on this lower side. Bicarbs are also on the lower side. So both are on the lower side. So what you will going to label at this condition? Over here, because this is actually, if you look at it, this ABGs, and the options also, okay, respiratory acidosis, you cannot label it because your PCO2 is low. Okay, so with low PCO2, you cannot label it acidosis. In the third option, again, you cannot say respiratory acidosis, mixed picture, because over here the respiratory PCO2 is going downward direction. If PCO2 is on the higher side, then only you can think about why you say compensated, because pH is normal. That is why you are saying compensated metabolic acidosis, which is a rare condition. As I mentioned, compensation, fully compensation is, it's very rare. Okay. So with fully compensation, how can you say that? Because your pH become almost normal. Okay. Complete, right oculomotor nerve injuries associated with ptosis, and otherwise there will be mydriasis, dilated pupils will be there, and eye will be downward and outward. 97% drug will going to be metabolized, will going to be eliminated in the 5 cycles. Pathophysiology of ITP, we know that this is a full-term baby, weight is good, whose platelet is 95, liver, spleen, just palpable are not that significant. So this is very important that you should know the mother status as well. If mother is okay, then you will label it as alloimmune. If mother involved, then you will go with either autoimmune or maternal ITP. So the decision will be based upon by looking at the maternal platelets. Okay. Now, the 7-year-old girl with the relapsed ALL who refused chemo to avoid repeating the experience of side effects. Her parents want her to complete the therapy. Her competence is accepted. What you are going to do over here, okay? So they say you go with the legal authority in the hospital, okay? Because again, this is the age in which she cannot reject, and the treatment, she's 15-year-old, and despite we know that the prognosis are not very good because this is the recurrence is there. So that is why you will go with the local authority. If it's a primary first time, then you will act according to the parents' wish. So it's basically depends upon the prognosis. If the prognosis is poor and the child is not competent, it's not willing, then you can go and proceed with the local authorities, okay? Fecal calprotectin is a Crohn's marker, preterm baby with long line. We discuss epidermidis, ADHD. What are the receptors? So ADHD receptors are present in the hypothalamus. Hypothalamus is the one which is producing the ADH, and then it goes to the posterior pituitary. So this osmolality changes are picked up by the hypothalamus, and ADH is produced by the hypothalamus as well. 7 months with wheezy chest, dyspnea, and oxygen saturation. 90% after salbutamol become it's 89. So we all know that at the 7 month we don't have actually be a proper beta 2 receptors are not there. This is the reason that this child is not responding to the salbutamol. So it's not inflammation rather than the bronchoconstriction. No, it's basically your beta 2 receptors are not working at the age of 7 months. Okay, you have it, but they are not mature, they are defective. So answer would not be the 2. Okay, it would be basically it's not basically bronchoconstriction or inflammation. It basically the beta 2 receptors are not matured enough. Okay, the answer would be 3 at the age of 7 months. Which bacteria attacked by T cells? So we all know that T cell is mediated by the TB mycobacterium. Newborn with the bradycardia. So bradycardia is anti-Rho and anti-La antibody, which is associated with maternal SLE. Lactulose mechanism of action is, so lactulose will going to cause active secretion of water and electrolytes in the colon. So this is actually both the water and electrolytes, both will going to be used with the use of lactulose. This is the child came with the vomiting, irritability, and if you look at the investigation that shows the ammonia is 750, lactate is mild, elevated, along with the metabolic acidosis were also there. So this is metabolic acidosis if it is there, and slightly high ammonia is also there. So most likely that would be organic acidemias. Okay, MCAT would not present with come with vomiting, irritabilities. No, this is not the scenario for MCAT. We have clearly mentioned metabolic acidosis is very clear for the organic acidemia. Urea cycle disorders are associated with respiratory alkalosis. So with high ammonia, 750 is the high ammonia, and with the metabolic, you will go with the organic acidemia in this case. Okay. Baby comes after the operation, has macrocytic anemia, dry skin, diarrhea. What is the operation? So macrocytic means terminal ileum is involved, B12 absorption is involved. Diarrhea is due to the bile salts you are losing that cause secretory diarrhea. That dry skin because of vitamin A, you cannot absorb it. Okay. So neonate 2 days come with tachypnea, cyanosis, difficulty in feeding, no murmur. Lung is plethoric. So over here, the word is plethoric. So lung plethoric means it's the, and it is the 2-day neonates. Okay, and with no murmur at all. So that is why it is more likely the TGA, transposition of the great arteries, the most common over TAPVR. In the TAPVR, also your lungs will be plethoric. Okay, so both condition, the situation would be very same, but you will go with the common condition, which is transposition over TAPVR. Okay, now the reverse closed foramen ovale left to right shunt. Why this is occurred? You know, because of increased pulmonary blood flow. Why pulmonary blood flow is increased? Because of the pulmonary vasodilation. So the 2 is right. That leads to the closure of the foramen ovale. Baby come with hemangioma, easily bleed in scratching. What is the origin? So this, we know, we just discussed blood vessels are present in the dermis. So that is why it is dermal in origin. Okay. Preterm baby, it's 35 weeker and RDS. Take oxygen on day 9 by examination, show absent bilateral red reflexes. Okay, so this child will present with the cataract and absent bilateral red reflexes are there. And what do you think? So as I mentioned that the retinoblastoma is an acquired condition. It will not present on the day 9. So most likely this child would be the CMV one. The bilateral cataracts is reflecting the systemic infection. So why not you will go with over here is the galactosemia will present later on. Yes, galactosemia will present later on, and I think it's not retinoblastoma. Retinoblastoma is an acquired condition. Later on it will present. So I think in this case you can go with the what I said. You can go with the CMV infection. Okay, so CMV infection can present with the cataract as well. On the camp, C 5-year-old child wanted to refeed. What is the most important? Vitamin decreases the risk. On camp, C child 5-year-old weight 10 kg want to refeed. Okay, so this is a failure to thrive child, 5-year weight 10 kg want to refeed. What is the most important vitamin that would decrease the risk of it? So thiamine is very important. Yes. So yes, this is right for alcoholic people or those who are very malnourished people. The thiamine deficiencies are very common in this children. So that is why they are saying what is the most important vitamin that decreases the risk of refeeding. Probably this is the thiamine deficiency. Okay, thiamine is the one. Okay. Now, next case, we talk about 10 days come with the difficulty in feeding, breathing, examination, show pan-systolic murmur. Heart rate is 180, respiratory rate high, hepatomegaly, normal saturation. What is the cause? This is 10 day now, so difficulty in feeding and Pansystolic murmur is there. So most likely is the VSD murmur. And what happened in the VSD? That low pulmonary resistance, high pulmonary blood flow towards the lung, and it is associated with left to right shunting. So this is the case in which there will be more left to right shunting is there. And why pulmonary resistance will be low? This is the normal phenomena. With the time, the pulmonary resistance will be low, the blood flow will going to be high, the blood will, it will congested your lungs. That is why you will be tachypneic. So this is the pathophysiology of the VSD. 4-year-old in preschool has disruptive behavior, how to manage. So this is a child which is 4-year-old, definitely it require more the parents, how to, parents will going to be the one which needs treatment, which needs therapies. Disruptive behavior means that is more likely towards the OSD, what we discussed before conduct disorder. What was the initial stage? I think I forgot the name. I forgot. You can recall me. It's the milder version of conduct disorder. So this type of behavior, it is, if it is there, this is best managed with the, it's not autism. ODD. Okay, ODD. Defined disorder. Yes. ODD defined disorder. Okay. So this disorder is, if it's very younger child, then definitely you oppositional defined disorder. Good. Oppositional defined disorder. Thank you. Okay, so this is, so first thing is the parental at the age of 4 years. Okay. How to deal that child. Okay. Pharmacology, treatment with risperidone, nothing. You will not go with the treatment pharmacology. Neonate come with the left lumbar mass. Ultrasound show pelvic and calcial dilatation. Bladder not affected. So you can see over here, if your dilatation on the upper side, okay, most likely it is PUJ obstruction. And this PUJ obstruction that is caused the pelvic and the calcial dilation, your ureters are not dilated, bladder is not affected. Okay. Child comes to RTA, what makes the cranial nerve unreliable in the brain death. So this is very important that if your core body temperature is very low, when you are checking the brain stem reflexes, that can makes the brain death unreliable. So it is very important up to 36 degrees centigrade, 36, yes, 35 to 36 degrees centigrade body temperature, you should maintain it first, and then you will going to apply the brainstem death testing, then check it. Okay, so this is very important. Neonate present with collapse, and you can say that heart rate is 145, capillary refill time 4 seconds, oxygen normal, receive bolus of saline, antibiotics, investigation high potassium. This is definitely, then first step is always you give the calcium gluconate. This is CAH case, and you first give the high potassium with the calcium gluconate. 8-year-old boy come with the vomitings and drowsiness, and if you look at blood pressures are low, glucose is low, take normal bolus, labs में potassium is high, sodium is low, that is most likely Addison disease. Okay. Chemotherapy of foot drop, we know that common Peroni, vincristine is the one. Children with the rickets. Okay, so this is the rickets, and if you look at this, sodium is low, potassium is low, chloride is 105, pH is 7.2. So pH is 7.2 means that this is the child presented with the metabolic acidosis. Most likely RTA is the cause of, as we discussed, rickets with acidosis. This is clear-cut RTA. What type of RTA? The urine pH will tell you urine pH is acidic. That means the problem is not the distal, because in the distal you will never have acidic pH. You will always have alkaline pH. So acidic pH is signify the problem in the proximal part. Okay, कोई बात नहीं, आप अपने से खेल लो. बस खत्म हो गया, लास्ट पेज है बेटे. Okay, come here. As a failure, this is, I think this point is clear why I will not select the distal tubule. Okay. Okay, baby post meningitis oliguria. So this is very specific. Oliguria is only in one condition with the hyponatremia, that is SIDH. Okay. Now next is CSF analysis show lymphos is more prominent. So, and glucose is very low, protein is very high. That is why they prefer TB meningitis over viral infection, which use in parametric studies. Parametric studies may you need, height is because it's a number. So in the numbers that can be used in the parametric study. Okay. Parametric, I think. Incidence of circumcised boys and UTI and uncircumcised and UTI. Ask about NNT, want the equation. So what was the, so incidence you will going 1 divided by, so the incidence is over here in the circumcised boys versus uncircumcised boys. Okay. And then 1 divided by this minus is basically telling you absolute risk. Okay. So you will take out the absolute risk over here. This is the equation. Baby come with the vomiting and lethargy. High potassium, this is sodium, low hypoglycemic CH. So Alhamdulillah, we have covered this paper as well. If you have the questions which we were having difficulty, you can just send me. I will inshallah confirm the answers for those questions from other seniors inshallah. And I think we have discussed. Kindly explain 34. Okay, dear. 34 is basically, if you look at this question, I can explain you tomorrow because my child is not tolerating right now. He's, so we will inshallah discuss in detail because this is genetic. I'll make a picture and then explain you. So just remind me tomorrow, Rabi. Okay. Thank you so much, everyone. Now we will going to discuss tomorrow, inshallah, the February paper with you people. Okay. FOP and TAS. Allah Hafiz.
I love it.